Hello, my name is Adele and I'm a consultant surgeon and I'm the chief investigator for the LORIS study, and I'm here this morning to answer any questions that you might have about this study, having read through the patient information leaflet.
Hello, my name's Daniel Ree. I'm a medical oncologist and I'm helping with the LORIS study, and I'm here to help answer any questions that you have to help you make a decision as to whether you wish to take part in the study.
DCIS stands for ductal carcinoma in situ, but is it cancer or not? I can't work it out.
There's great difference of opinion in the terminology for DCIS. So the term DCIS means that there are abnormal cells when you look down a microscope. It has been called for a long time an early breast cancer, but that implies that it will go on to become an invasive breast cancer. And we now have a lot of evidence that a majority of low-risk DCIS will not go on to become a breast cancer.
Are you saying that DCIS is not a cancer?
It's a question of what your definition of cancer is as to whether DCIS would be regarded as a cancer. The cells look abnormal in DCIS, so they've got rather large centres or nucleuses, and the cells themselves are slightly abnormal, and they cluster in a ball inside the milk duct. But what they don't do is show any evidence of spreading outside the milk duct. And so they are not invasive, and it's the invasive part of a cancer that I regard as the serious and dangerous thing that a cancer can do, because while it sits in the milk ducts doing nothing, it's doing you no harm at all, and if it's going to stay like that, then I don't think it's a cancer. If you've got cancer that spreads, that's what I regard as a cancer that's going to actually have some negative implications for your health in the long run.
Can you tell me, what is randomisation?
Yeah, randomisation is a term used to describe how we allocate patients to one group or another group. It involves essentially putting your name into a computer, and the computer will then allocate you to one group, either surgery or to active observation, and neither you or I will be involved in how that decision is made. It's made on a purely random basis. The purpose of the randomisation is to ensure that all the differences that there might be between the groups are equally balanced. And it's very, very important when we're trying to do a research study that will change practice and make doctors believe the results, that we perform it in this randomised way, because otherwise it's very easy to say that we put different patients with different characteristics into one group versus another, and that results won't be believed. So we have to go through this process of randomisation, and it's confusing to start with for patients to get their head around why that's necessary, but if we don't do it that way, then the results will not be believed.
I am interested in doing this study, but really I wouldn't like to have the surgery. Would I be able to just take part, but if I got randomised to the surgery, then I could withdraw?
I think to be eligible to take part in this trial, you have to be able to accept randomisation to either arm, so that if you felt very strongly one way or another, then this trial is probably not the appropriate way for you to have your treatment. I think I should add that because we've always treated DCIS by surgery, doctors feel that the safest way to start not operating on patients is within this safe environment of a clinical study, where in the active monitoring arm you will be closely monitored with access to specialist advice all the way through the monitoring, which initially has to be long term for the first ladies that have this. So we wouldn't recommend not having surgery outside of the trial, and it would be quite unusual to be offered the choice at the moment of not having surgery.
So I wouldn't be able to be actively monitored outside the trial?
I think nobody could ever be forced to have surgery, but people with DCIS are not currently usually offered a choice. And if you did decide not to have surgery, of course you wouldn't have to have it, but you would not be actively monitored in the same way as if that took place within this study.
You said that I might be in one of the groups that would be active monitoring. Can you tell me exactly what that is and what would I have to do?
So if you're in the active monitoring group, every year you would be sent an appointment to come for mammograms. And after the mammogram, within 2 weeks, you would receive a letter telling you that everything was fine, or that something had shown on the mammogram which would mean that you would receive a hospital appointment to come up to have explained to you what the mammogram had shown and if there was anything else that needed to be done. You would also be given contact information so that if you had any concerns or worries at all, you knew where to come and that you could be seen in the breast clinic at short notice at any time with any concerns.
If I am part of the monitoring group, a year seems quite a long time between mammograms. Is there an option for me to have any additional checks during that time?
So in the active monitoring arm, you're correct that mammograms will be annually, just once a year. If you have any concerns at all during that year, then you have open access to come to your hospital and see your research nurse or your doctor. And if they felt any additional investigations were necessary, then of course they would be performed. Annual mammograms have been agreed on by the trial expert radiologists, X-ray doctors, because the changes that cause DCIS to turn into anything else or more new changes to appear are usually very slow, and that's one of the reasons why on the breast screening programme mammograms are every 3 years.
What happens if I get monitoring but then I get very anxious and decide that I do want to have surgery after all?
So if you're in the active monitoring arm and you get really nervous, our advice would be to contact your breast unit, speak to your doctor or your research nurse, and your clinical nurse specialist will always be very helpful. And hopefully we would be able to allay your fears. But if your anxiety was strong and you decided that you stopped wanting to take part in the trial, then you absolutely can, and you could decide to have surgery at any point.
What happens if I do get invasive breast cancer?
If you had an invasive breast cancer diagnosed at any time during the active monitoring arm, you would stop being in the clinical trial and your treatment would be the same as if that was picked up in any patient who hadn't been in this trial. So you would have surgery and usually some other sorts of treatment as well. That's very dependent on the sort of cancer that it is.
And in addition to that, patients in either arm of the study could get an invasive cancer. So even if you've had your DCIS removed surgically, it doesn't mean to say that you couldn't get an invasive cancer in a different part of the breast. And that's why we monitor patients that have had surgery for DCIS in case we see something new happen.
I have a friend who has had breast cancer and she has had hormone and radiotherapy. Would this be the case for me?
Well, I don't know quite what sort of breast cancer your friend had. Perhaps you had an invasive breast cancer where pretty certain that you have to have an operation in order to maximise your chances of being cured. But in addition to the surgery, we need to add treatments to help make sure that we minimise the chance of the cancer coming back. So we use radiotherapy, hormone therapy, and of course sometimes chemotherapy for advanced breast cancers. For DCIS, it's quite different. Now, 1 or 2 patients will be given hormone therapy as part of their treatment for DCIS after surgery, and a number of patients are also recommended to have radiotherapy treatment because that's been shown to be helpful in patients that have had DCIS operations. But for the majority of patients, it's just surgery alone.
Right, I don't like questionnaires. Is it possible to be in the study but not fill out the questionnaires?
Well, I hate filling in questionnaires as well. I think you're very important in this study, and your opinions and your views and your feelings as you go along are very important to us and future patients. So we would very strongly ask you to fill them in, and we can always provide some help if it's difficult to do so. You have to be able to fill out one of the questionnaires at the start to be eligible to, and it is a very important part of this study.
How long are they, and how long would it take me to fill them all out?
They're very short, so they take, honestly, a few minutes each, and there are 3 to do in the first year and 1 a year after that, up to 5 years.
I can cope with that.
Good.
It seems to me that the study's going on for quite a long time. Why is this?
At the moment, we treat DCIS of whatever sort as if it's a cancer. So we rush patients into hospital, usually within a couple of weeks of the diagnosis, and we have no evidence at all that we need to do so. So if we're not going to operate at all, we need to follow patients up really for a very long time if we're going to stop operating, because we need to know over a long period of time, is the DCIS going to remain the same, in some cases go away, or if it's going to get bigger or need any treatment, we need to know if it's going to do that not just within the first few years, but over a long period of time. So it's really to answer all of the questions surrounding not operating on patients in whom we currently do operate.
So to fully understand exactly what the natural history of this condition is, we're going to need to follow you up for a very long time.
If I moved house to another part of the UK, would it still be okay to be part of the study?
Yes, it is. It's UK-wide and likely to be in other countries outside of the UK as well. And so if you were to move anywhere, there will always be a centre reasonably close to you where you would be able to continue with your either active monitoring or treatment or follow-up.
What if I've been in the wrong group?
We won't know until the results of this study are available whether there is a wrong group. So if the study shows that it's safest in the long run to everybody to have surgery and you are in the active monitoring arm, then at that point it's likely that surgery would be discussed with you. If the study shows, which we expect, that surgery is not necessary and you had surgery to start with, then obviously that can't be undone. But that is the standard treatment at the moment, and your participation in this study will have benefited all the future generations of women who are diagnosed with DCIS. And I think we should remember that the breast screening programme wasn't set up to find DCIS. It was set up to find breast cancer. And DCIS wasn't hardly ever diagnosed before the screening programme. And once we started doing mammograms and we saw these dots of calcium which show DCIS, we treated them because we didn't know what else to do. But that's not the purpose of the screening programme.
Will the results of the trial change the way in which we are monitored?
I think the results of this study are very likely to alter the way in which we treat DCIS. But for the ladies taking part in this trial, I think monitoring has to be this first group of patients not undergoing surgery. The active monitoring has to be lifelong or very long term, and we're all agreed with that. Does anybody else have any questions or worries that they haven't asked us? If you do have any other questions at all or worries or queries before you decide whether to take part or not, or at any time subsequently, then don't hesitate to ask your research nurse or your doctor or your clinical nurse specialist, and one of us will always be able to answer them for you.
Thank you very much for coming and thinking about taking part in the LORIS study.